Hi YouTube. I messed up. I'm sorry. You guys are saying that, oh, I can't see the knee. Why can't I see the knee? Well, now we have some knees and attached to a student. Fiona, say hi to YouTube. Hi. So we're going to talk about knee anatomy again, but with you being able to visualize it, which is good. I'm going to be drawing so you can see exactly where the structures are. We're also going to talk about fibular head. We're going to talk about biomechanics. So let's get into it. You want to line your back for me? We have knees. Knees are hinge joints, right? Your patella, right? All right, here's the fun part. This is where I start to draw. So we have the patella, right? And you can see it right here, a little patella, and we'll draw a little smiley face. There you go. So we have the patella, or the kneecap, okay? We have our quadricep muscles. So you have your vastus lateralis, CVL. Here, she's trying to see too. No cheating, just kidding. You can watch your VMO, vastus medialis obliquus, and you have rectus femoris. Your vastus intermedius is underneath. Okay, a little bit of a quiz. Rectus femoris attaches to the AIIS, not the ASIS like everyone thinks. It's just underneath. So it kind of wraps all the way down like this. Okay. Now this becomes the quadriceps tendon. All of these blend into our little smiley face, and then it goes into the patellar tendon here, which attaches at the tibial tuberosity. We'll put a T there. So this is your tibia, right? Your tibial plateau and your tibial tuberosity. Implicated in Osgood Schlatters for kids, right? Jumper's knee, where you, because of Wolff's law, you get remodeling and you get some bony inflammation here that can be quite painful for kids. So we find that joint line, which is right here. So your LCL is going to be right here. And then your MCL, if we turn, here's your medial joint line, it's going to be right here. Your pes anserinus is right here, pes anserinus, which is going to be your SGT muscles, sartorius gracilis semitendinosus. That's that tendon, right? If you feel at the back of the knee, tendinosus, it's got a big tendon. The tendon on the other side is your bicep femoris tendon, okay? And then we talked about the patella, etc. So internal to these structures is going to be your lateral meniscus and your medial meniscus on the medial side, okay? So all that being said, let's get into some testing. We'll do it on the non-drawn out knee so we can stay focused here. So when you're testing, right, let's say we check some range of motion first. Any pain here? Nope. Any pain with full extension? She's got a little bit of hyperextension, maybe a little hypermobility. Yeah, she's got a little hypermobility. Okay, so that being said, no pain with flexion or extension. Then we check some drawer tests for the ligaments. So what I didn't talk about yet were I talked a little about the LCL, MCL, but your ACL and PCL are inside the knee. The ACL prevents the tibia from coming out towards me underneath the femur, prevents that tibia from shifting, and then the PCL protects the tibia from shifting too far back under the femur. So you just gently sit on the front of that foot, and I pull towards me. I don't feel any laxity. You also want to check the other side, but for the sake of time, we're going to do this right side, and then I push for posterior drawer PCL. For Lachman's test, you grasp behind the tibia, grasp the front of the femur, and try to pull up towards me. That also is a good ACL test. A little bit of flexion, about 30 degrees, okay? So that's checking for those ligaments. Now for the varus and valgus stress, you also want to hold at about 30-ish degrees of flexion. I'm pushing this way to stress on the MCL. So I'm pushing here. Any pain here? Nope. And then I'm pushing here for lateral collateral ligament. Any pain there? Nope. Okay. So there we have those. And then next we're going to check some McMurray's tests. So for McMurray's, we're bringing the knee into higher flexion here. I am bringing the leg close to me, internally rotating that tibia. I'm going to push in to check the lateral meniscus. So there's a lot of moving parts. So I'm internally rotating, pushing in, and then I'm straightening the leg. The reason being is we're creating a lot of pressure in that lateral meniscus. Let me grab my blocks. these blocks, right? Pretend the green block's the femur, the purple block is the tibia. So as we just slightly flex, internally rotate, and then if I push, look where all that pressure is. It's rubbing on that lateral meniscus here. So if I flex, externally rotate, and push towards me, it's rubbing on that medial meniscus. So let's do it. So medial meniscus, I am externally rotating, I'm pushing out, and then I'm straightening the leg. So again, it's like this motion. I'm always trying to put stress into that either lateral area or that medial area to test the actual cartilage inside, or those menisci, let's say. We also have patellar grind. So I'll try to push the patella towards her feet. I'll say, try to tense your quad. Ooh, we had a little clickiness. Any pain with that? No? I don't know, you're grimacing. Is it more of the clickiness that's weird? Yeah, okay. So maybe chronic, maybe past scar tissue. Any injuries in this knee? No? But again, so that's how you're checking for patellofemoral syndrome, chondromalacia patellae, any inflammation under the kneecap. You can also check for any fusion. So if I want to push up or ballot up and try to create a fluid pocket, doesn't look like she has an effusion, so that's good. But for a patient who's got a lot of osteoarthritis or knee pain, you might see a lot of fluid collection just above the patella. For that, and then we will do, if you want to lie prone, we're going to check some Apleys, okay? So for Apleys, you can do either compression or distraction. For compression, we're going to essentially just make sure the femur is secure, and then sometimes I'll actually load my shoulder and really compress down into that knee and just do a twisting motion. This is going to check the menisci as well. Now, if I want to pull up and check the ligaments of the knee, you can either give it a little like choke hold here and then rotate. Some people just, they're really big biceps, are nice and strong, they'll pull up and then rotate. I just think it's easier to get in, do this, and then pull up and rotate. That's gonna check the ligaments. And then one last one, if you wanna lie on your back again, I just forgot and realized the bounce home test. So the bounce home test, you bring the leg up and then you just go floppy and then you bounce, okay? You bring it up and you bounce. Now it's positive if on that full extension they have pain on that bounce. That means that maybe they have some inflammation going on. So that is about, did I miss anything? Oh, fibular head. What was the beep?
That was my question.
Oh, okay. You failed. No, I'm just kidding. All right, let's talk about fibular head. You want to come to this side so I can draw on this? Fibular head. So here is, again, how do we find it? Bicep femoris tendon going to the fibular head right there. So let's do a little, and then here's the fibular head. Here we go, okay? And again, that fibular head is contiguous with the lateral malleolus. It's the same bone, and it has a seesaw motion. So supinate your foot. There you go. So a little more plantar flexion. There you go. So that'll drive that fibular head posteriorly. And then pronate. A little more eversion. There you go. And that'll bring it anteriorly like this. A lot of it is dictated by the actual motion at the lateral malleolus, because when we supinate, it gets carried this way anteriorly. So that causes a posterior shift at the fibular head. And if we do the other pronation, so eversion, yep, that'll kind of bring it anteriorly. So that's the mechanics at the fibular head. And then you can diagnose by doing like a seesaw motion where you're grasping the fibular head, the lateral malleolus, and checking that motion. That's normal physiologic motion. Most people prefer a posterior fibular head because inversion happens way more often in terms of injuries. So again, that's going to be pretty common. You find like a posterior fibular head. Maybe they had a lot of inversions. Did you have a lot of sprains, inversion sprains? Not too much? Okay. So again, you might find that as a preference. It's kind of hard, honestly, to get injured in eversion. I only saw it once. I saw a patient jump off a fence and land that way, and it was like sprain their deltoid ligament. Here's another board's exam question, right? If they have an eversion sprain, the deltoid ligament is right here. Oh my gosh, now they're gonna say, you didn't expose the foot. So, sorry, but we're gonna roll this down. So the deltoid ligament, right, on an eversion sprain, it's kind of like right there. Okay, so if she everts, it's gonna strain that ligament. Now, if we invert, you have your ATFL, anterior talofibular ligament. It's gonna be on the talus and the fibula, so it's kind of like this direction. So that's like the main ligament injured with inversion sprains. I apologize, I didn't expose the knee last video. Hopefully this makes up for it. Tell me if you think it did in the comments. Thank you.